Assalamualaikum and a very good evening to all of you. Thank you everyone for joining our CME session tonight. Tonight we are delighted to share a very interesting topic that will be presented by Dr. Hafsah Sazali, our physician in dermatology department, and share the postgraduate diploma in clinical dermatology and also Master of Science in clinical dermatology. So she'll be the best person to talk on this topic. So the topic for tonight is description of skin lesions. So without further ado, I would like to invite Dr. Hafsah. Over to you, Dr. Hafsah. Thank you.
Thank you, Dr. Yakin. So I'll start sharing my screen now. So can you all see my screen there?
Yep, clear.
Right. So good evening, everyone. Assalamualaikum. My name is Hafsah. So today I'm going to present on description of skin lesions. This is a very straightforward topic, but yet very important because the way you describe skin lesions to the dermatologist will form the differential diagnosis, and it's very important for you to think about the different points that you have to determine in terms of the morphology and also description of skin lesions in order to know whether that is a dermatology emergency or not. Okay, so in terms of describing skin lesions, there are a few different things that we have to focus on. First is the morphology, and that can be the primary or secondary changes in the skin lesions. The color, of course, we love colors. Distribution, whether it's localized or widespread or other kinds of distribution, which we'll go into later, and also the site, of course. So the first question you have to ask is it a flat or raised lesion? Okay, when I say lesion, it's usually the dermatologist would refer lesions to solitary or just a few different lesions, but this will also cover the rash or eruption on the body. Okay, so the first question is whether whether it is flat or raised. So macules are flat, usually well circumscribed, discolored lesions, which are small, less than 0.5 centimeter, and patches are flat, usually well circumscribed lesions more than 0.5 centimeter. And we move on to the raised lesions. We have papules, which are solid raised lesion less than 0.5 centimeter, and nodules, which are solid raised lesion more than 0.5 centimeter. So we can see here there's a papule on the left side and nodule on the left side. And you can, based on these lesions, there are a few differential diagnoses. If you have any questions later, just type it into the Zoom chat or Facebook Live, and we'll go through the questions, okay? And plaques, so plaques are also raised lesions, usually with a flat surface, but it lacks the deep component that is there in nodules. So usually they are larger, more than 2 centimeter, and they usually have scaly surface. Okay? Wheals are the term that we use to describe hives or urticaria, and these are usually firm edematous papules and nodules and plaques, and they are usually pruritic. The second question is, are there any fluid-filled lesions? So we have vesicle, which are papules containing clear fluid less than 0.5 centimeter, and we have bullae, which are large fluid-filled lesions more than 0.5 centimeter. And pustules are fluid-filled lesions containing pus, which is less than 0.5 centimeter. So does anybody have any idea what the what pustules are present in, which conditions present with pustules. And we can see here, it looks like the heel, doesn't it? Anyone would like to have a guess on the differential? So you can reply in the chat room and we'll go through it later, okay? And cysts are also raised lesion. It contains fluid or semi-solid content. Okay? Besides the primary features, we also look at the secondary features, secondary changes such as scales, which are basically hyperkeratosis, and crust, which can consist of dried debris, serum, or blood. Okay, and usually these are a result of bursts, blisters, or pustules. Lacinification is also a term that you use usually in skin conditions where patients repeatedly scratch or rub their skin, and this causes thickening of the skin with accentuation of skin markings. This is called lacinification. And in a way, we know that these are chronic skin conditions, chronic pruritic skin conditions. Okay? So atrophy, we can so it's thinning of the skin. So it can you can have thinning in the epidermis, dermis, or subcutis. So when you have thinning of the epidermis, you can see secret paper wrinkling on the skin, and you can see the shiny appearance as well. But when there's thinning of the dermis or subcutis, there's depression on the skin which is visible. Okay, so you can see epidermal thinning in this picture. Also, we can there are other clues or signs like excoriations, scars, post-inflammatory hyperpigmentation or hypopigmentation, which suggest that the patient has been having that skin condition for quite some time. Other than that, we can see fissures, which is basically cracks on the skin, linear cracks on the skin caused by vertical loss of epidermis or sometimes dermis, depending on how deep it is. We also have erosions, which is a focal loss of epidermis, which does not cause scarring. And we have also ulcers, which is a focal loss of epidermis and dermis, and these will cause scarring when it heals. The next important aspect of description of skin lesions are, of course, the color. So is it erythematous? So basically, when you say erythematous, when you palpate or press on the skin, the skin will, the redness will blanch on pressure. So these are non-blanching erythema or purplish lesions are vivacious or usually purplish, and they don't blanch on pressure. So here we can see purpura and also like petechiae. So petechiae, purpura, they are all non-blanching vivacious lesions, and these can be seen in conditions like ecchymosis and also vasculitis. And of course, there are lesions which are completely white in color. So, for example, we have calcinosis cutis just under the skin here, which is deposition of calcium, and these are white in color. And also in vitiligo, we have total loss of pigmentation on the skin, which also cause white patches. And brown color, here we can see light brown, fairly well-defined patch, which is present in patients with neurofibromatosis, which is called café-au-lait spot. Black lesions, it can occur in necrotic skin, and also down here we have a big nodule consisting of black pale areas. It's a must to do dermoscopy on these lesions. And this is really concerning of melanoma, basically nodular melanoma. So this is something that should worry you when you see it, okay? Grayish discoloration on the skin that can occur in patients taking some medications such as amiodarone. So we call it, we describe it as slate gray pigmentation on the skin. So it's quite subtle on the picture above this, but it's more prominent on the picture below. Green discoloration, for example, in onychomycosis, and blue color in, for example, blue nevus. I would like to actually remind that sometimes it's difficult to differentiate between blue nevus and nodular melanoma, because obviously when the melanoma is deeper, it gives this grayish blue discoloration. So history is really important. And if you're not certain, you have to consider excising the lesion. Okay. Yellow, for example, in xanthelasma, here we can see a well-demarcated plaque on the right medial canthus extending to the eyelids. Of course, you have to check the history, check the fasting lipids, and they can also get xanthomata as well in these patients with hypercholesterolemia. Salmon red. This is this color is classical color in pityriasis rubra pilaris. The patient happens to be holding an orange colored toy truck. So you can see it's not just red; it's actually orange red color, which is common in pityriasis rubra pilaris. So we also have hyperpigmented skin conditions. A common example is melasma, and hypopigmented macules and patches, as we can see on the right-hand side of the screen. So this can happen, for example, in pityriasis versicolor. So the next point is actually the distribution, because there are certain skin conditions that typically present in certain distribution of the skin. So for example, you can see here a well-demarcated crusty plaque on the elbows, which have a symmetrical distribution. So sorry, on the knees. So you should also look at the other extensive surfaces like the elbows, and other typical sites like the scalp, the umbilicus, the perianal area. So those are the typical sites for psoriasis. And some of the skin lesions are grouped. For example, cold sore or HSB. They are all usually presenting with group vesicles on an erythematous base, and it can be quite sore. And this is also, the picture doesn't project very well, but mainly we don't see vesicles, but erosions on an erythematous base in a dermatomal distribution. So we would think about herpes zoster in this case, and some skin conditions occur in the acral side. So that means the extremities, the palms and soles. In these two pictures, we can see hyperkeratosis and punctate keratoderma in the acral sides, which occur in palmar plantar keratoderma. Besides that, the shape of the lesions, the configuration of these lesions also matter. For example, linear distribution. These can occur, for example, in curved nerve phenomenon. So psoriasis is one of the skin conditions which can demonstrate curved nerve phenomenon. We can also see that in some allergic contact dermatitis, poison ivy, for example. So it does give us a clue of of the differential diagnosis. And some conditions also occur in annular pattern. So, for example, a common example is tinea corporis, which has a scaly raised border with annular shape. But there are other skin conditions which can be annular as well, like this called eczema and granuloma annulare. They can all occur in annular pattern. Okay. Serpiginous is another special description that we use to describe lesions which are wavy, like it's like a snake. So you can see there that we have a wavy lesion, like a snake which is quite elevated on the skin. So I'm actually, this is possibly like a spot diagnosis that everyone knows, I hope. And you can type in the chat room what your impression is. And another important description, which is which is specific really, is targetoid. A lot of people describe targetoid for annular lesions, but targetoid is very specific actually because it has 3 zones. The middle zone is the dark or blistered center, which usually has a dusky color. This is followed by the second zone, which is the pale zone, followed by a rim of erythema. So there are actually 3 zones. If you want to describe something that is targetoid, they have to have these 3 zones. Okay? And sometimes we do have atypical targetoid lesions, but if you want to say it's targetoid, it has to have these 3 zones: the dusky center, blistered center, the pale zone, and followed by the erythematous rim. This is targetoid. Okay. So just to sum up, this is actually to recap what are the important points to communicate to the dermatology team when you're referring a patient. The first is morphology. Think about the primary features. What is the morphology of the lesion, and if there are any secondary features accompanying the skin lesions. The color, of course, and whether it's blanching or non-blanching, and the distribution, whether it's localized or widespread, or is it symmetrical, and of course the sites affected by the skin lesions, because there are some typical sites that is affected in certain skin conditions. And it's very important to palpate, is it a soft lesion, a firm or hard lesion, and these is all very helpful in forming differential diagnosis. And don't forget to examine the special sites. So people often forget the scalp, the nails, and the mucous membranes. The scalp is commonly affected by conditions such as psoriasis. Nails also can be affected by psoriasis and some connective tissue disease as well. Mucous membranes, particularly important in examining patients with bullous disease. And these, if you have this information, we'll be very happy actually. And of course, you have to take a good history and make sure you have all the results of investigations relevant to the patient. So I received a request to go through some pediatric dermatology cases. It's actually a lecture on its own, but we'll go through 3 cases for today, if that's okay. So the first case is a 2-year-old who presented with a loss of appetite, lethargy, and constipation for about 5 days. He's also experiencing pain on nappy area, the trunk, neck, and face. And there are blisters noted in the perioral area, and Nikolsky sign was positive. And I would like to know actually if people are aware of the Nikolsky sign and what it is. So please type in the chat room what your answers are. Case 2 is a 3-week-old neonate with a red patch on the left side of the face, which is present at birth, and this has grown proportionately with the child. So let me know what your differential diagnoses are. And the third case is a 2-month-old female with a red spot on the scalp, first noticed at 2 weeks of age, which is rapidly growing at 2 months old. So I'll be interested to know what your diagnosis is in this based on this case. Okay. So these are my references, and I would like to make it interactive. I would like to know what your questions are so that I can make it clear. So I possibly I want to Is if there are any questions, and we'll go through the answers of the cases, of course.
Okay, thank you very much, Dr. Hafsah. So we have a few questions. Most of the answer given by the by the audience. Actually, they didn't put which case. But never mind. We will talk about it later on. So one of the question is from Muhammad. Muhammad, no, salam doctor. I have two questions. How to describe hyperkeratosis? And second one is what difference between keloid and hypertrophic scar?
How to describe hyperkeratosis? So hyperkeratosis presents with scales or crusts. When you say hyperkeratosis, it's actually the pathology process that happens in the skin. So, well, scales represent hyperkeratosis, but hyperkeratosis is not a description of skin lesion. Is that clear?
Okay. And the second one is what is the difference between keloid and hypertrophic scar?
So it's actually quite difficult to differentiate. Keloid scar of they grow, and hypertrophic scar is elevated, but they don't grow. Okay.
Okay. There's one question from Dr. Loba. So the person is asking is the patient have a keloid. So maybe you can tell us a little bit how to treat keloid, Dr. Hafsah.
Okay. All right. Usually, it's actually quite challenging to treat keloid because it's quite painful, right? One of the treatment that we often use is intralesional steroid. Okay, because usually topical steroid is not that effective, especially if it's a big one. I've actually done some attachments and I've seen people performing laser surgery on that. So, but I don't have much experience in it. So it'll be interesting to get, shared experience from plastic surgeons and dermatologists who do that.
Okay. Okay, the next question is from me, Dr. Hafsah. Just want to know, I think most of the most common presentation for patients with dermatological condition is eczema. Can you tell us a bit how to detect eczema and the how to treat eczema?
How to treat? Oh, this is actually a lecture on its own. Is okay. So basically, you have to take a good history and physical examination. The treatment can be divided into topical treatments, phototherapy, and systemic treatments in general. Okay, but it depends on a lot of factors. So it can be, is it mild, moderate, or severe eczema? Is it responding to topical treatments? What is the patient's medical history? Those are all important in order to determine the appropriate treatment for the patient. So it's not a straightforward question, but we can certainly have a session on this topic in the future.
Okay. The next question is from Dr. Anwar Fazal. How do we approach Neva?
Neva, okay. Taking a good history is very important. Okay, to know when did the Nevas start. When was it first noticed? Okay, and then there's ABCDE. Have you heard about ABCDE approach?
No, you know.
No. Okay. So you look at the asymmetry, whether it's asymmetrical, whether it has irregular border, color variegation, okay, and the diameter has a large size. For example, I think the cutoff is 6 millimeter, and then the evolution. So it all, I think it's a combination of these the history given and also the features that we see. And here we use dermoscopy to look at the dermoscopy features and see if there's anything worrying. I think in here we see melanoma more often, but in Malaysia we do see melanoma as well, but there's more of acral lentiginous melanoma too. Have you seen any is by any chance?
Yeah. Pardon me? Pardon?
Acral lentiginous melanoma. So it happens on the nail area, usually on the foot. Okay, that's more common in pigmented skin types as well. So it's very. So how do you describe approach Nevas? First, take a good history. and then make sure you know exactly when did the lesion start, and has it changed in size, shape, or color, and history of immunosuppression is very important as well. And here in the European country, it's important to know whether they have used sunbeds, that they do sunbathing a lot. But maybe it's not really relevant in Malaysia because everybody is trying not to be exposed to the sun. But it's still very relevant because we have a lot of Caucasians, expats and foreigners in our country. So change in the lesion, risk factors, skin type, and also the morphology of the lesion, and dermoscopy will help to us to see if there's any suspicious features that is not visible on naked eye. But yeah, if there's any history of change, and on this atrial sides, you can see Hutchinson sign. So you can see that it extends beyond the nail. So if it's positive, it's very suspicious of melanoma on the.
Okay, good. Thank you, Dr. Hafsah. The last question for the session before we go to the case basis question. So this one is from AJ. Quite good question. Can you explain about face mask acne versus allergic dermatitis? Since recently at GP, we seen quite a lot of cases of acne using face mask.
So maybe the question is whether there's is dermatitis, allergic dermatitis versus acne on the face, is it due to mask?
Yeah. They want to ask whether is it the face mask causing acne or the versus allergic dermatitis. I think it's most the same lah, because the face mask causing the dermatitis is it the dermatitis can cause acne?
No, dermatitis is usually referring to eczema, facial eczema. Okay, most of facial eruption from masks are actually acne, maskne they call it now. So allergic dermatitis is actually a specific type of dermatitis caused by allergy. So you have to get a patch testing to confirm it, but it's based on the history as well. Usually, the face mask is causing acne because of the occlusion of it's actually occlusion basically, and on top of that, sometimes people wear makeup, occlusive makeup, and then the mask is all contributing to acne because it's basically the pathology is the occlusion of hair follicle, and which develop into comedones and then papules, pustules, and cysts and nodules. So dermatitis usually we refer to skin conditions in eczematous skin conditions, and of course we have atopic eczema, we have irritant contact dermatitis, allergic contact dermatitis. But allergic contact dermatitis is very specific to people who are allergic to the substance that they're exposed to, and that needs to be by patch testing basically, hypersensitivity. Okay.
Okay, thank you very much, Dr. Hafsah. Actually, we have another one question from Dato' Azamani. Can you simplify principle of skin eczema treatment? When to use or not to use steroid, moisturizer, and antifungal?
When not to use? Oh, these are very specific. When to use a moisturizer and antifungals? Well, use antifungal if you think that there are fungal infections. Moisturizer is an important maintenance treatment in eczema, so they have to use moisturizer regularly and also use a soap substitute or soap-free cleanser to clean their skin, especially when it's acutely flaring. Topical steroids, when to use, when to not use topical steroids. Okay, this is really dependent on your assessment of the patient. So one thing I would say is sometimes people they have family members who have topical steroids, and then they see a patch on their skin and they use the topical steroids to treat basically any patch that they get on their skin. But this is strong, okay? So you should only use topical steroid when that the doctor prescribes you after assessment. You shouldn't use topical steroid, borrowed from your family member or your friend, because you're not necessarily treating the right skin condition with the right treatment. Okay, it's quite specific actually, because when you say eczema, is it eczema or is it other skin conditions? Use a lot of for itchy skin conditions. Topical steroids are used for different itchy skin conditions, and sometimes people use it on non-itchy areas as well, which is wrong. Okay, but there are other non-itchy skin conditions that we use topical steroid in. So that is a different topic, and so I cannot say don't use topical steroids in these skin conditions. Use topical steroids in these conditions. It's really important to get important history and perform an appropriate physical examination and get the diagnosis right before determining whether you should or should not use topical steroids. Sorry, I cannot answer that question.
Okay, so the follow-up question from Dr. Azamani is, I think because actually this kind of skin lesion like eczema, there's too many case in ED, and then they have they cannot refer direct to dermatologist usually at night. Okay, if the patient is really eczema, they have eczematous rash, what kind of concentration of a steroid that we need to give before we get the proper review by the dermatologist?
So we have mild, potent, potent. So mild, moderate to high potency or very high potency for topical steroids. So it depends on what you have in the department, right? So I think A has different topical steroids available to them. ED has different topical steroids. But if it's really acute in general, I would say like they need at least potent topical steroid to alleviate their skin condition. Okay, moderately potent. So we have mild, moderate, potent, very potent. So at least moderately potent to start off, and they need follow up basically. Firstly, I think it is inappropriate for patients to be to be seen in emergency department for eczema. It's not the right setting. But anyway, it is what it is, and I understand that you have to deal with it. But usually, and it depends on the on how severe it is and what are the sites of the skin that you treat. So of course, you wouldn't use potent or very, moderately, potent topical steroids are not appropriate for skin areas which are thin on the flexures, for example, axillae, groin, face. You shouldn't use potent topical steroids on this area. That's why they have to have a follow-up, because if topical steroids are not used properly, it can cause side effects. So I cannot give specific advice for patients that I don't see, but it's actually quite, so I think it's important to know what are the topical steroids available. So mild topical steroids like hydrocortisone is safe to use on the face and the flexural area, groin, but potent topical steroids, if not used in the right way, can cause thinning of the skin, especially if it's used on these areas which are which are quite thin, so face, flexures and groin, just be careful with that. Okay.
Okay, I think we have one more question, Dr. Hafsah, from, I think this one is from non-medical side, from Anis Hafiza. How to differentiate contact dermatitis with fungal skin infection clinically? Previously was misdiagnosed and given antifungal, but no improvement after weeks in GPs.
History. So, history is very important. Well, I don't know what, I don't know the history of the patient, but contact dermatitis, you have to take a good history. When did it happen? If there's any, the natural cause of the rash, and also if there's any contributing factors, do they have any hobby? What are their occupation? Did they do any gardening? So I'm not really sure what the history is, but contact dermatitis is is something that we suspect based on the history, and then we also perform examination, and based on the two, if there's a suspicion of so contact dermatitis, by the way, it can be divided into two: irritant and allergic contact dermatitis. Okay, for irritant contact dermatitis, it is caused by direct effect of the substance to the skin. So you don't do patch testing. Okay, but if you suspect allergic contact dermatitis, then you have to refer to dermatology and assess if they need patch testing. Okay.
Okay, thank you very much, Dr. Hafsah. Can we go to the first slide that you shared just now with the heel, with the multiple pustule?
Okay. Okay. So 2-year-old.
No, the first one, Dr. Hafsah, the one that you asked, because some of them actually answer the heel lesion.
Okay. All right. Yeah, this one. So what were the answers?
Okay. Most of them, K Kamal answer pustule or furuncles, and then Amina say it's a chicken pox, and then Nadira say it's a bacterial infection of the lesion.
Bacterial infection. Okay. All right. This is actually plantar psoriasis. It can occur in common plantar psoriasis. So we have a type of psoriasis which is called plantar pustular psoriasis. Okay. What were the answers again?
Most of them actually we got three answer. Three answer. One is chicken pox. Second is pustule foruncles. The third one is bacterial infection of the lesion.
Okay, all right.
Quite broad.
So of course you have to look at the do a full skin exam and see what is the distribution of the pustules. Okay.
Okay.
We also have sometimes like generalized pustular psoriasis. It can affect the any parts of the skin, not just the palms and soles. This is like a chronic pustular psoriasis and the palms and soles. These are chronic skin conditions, but we also have acute generalized pustular psoriasis, and the patients can be quite sick with it. Okay, so that's medical dermatology emergency that you have to know of. But this is actually on the heel area. Okay, so this can occur in palmoplantar psoriasis, pustular psoriasis.
Okay, noted, Dr. Hafsah. So now we go to the first case, Doctor.
Yes. Okay, the first case. So what are the answers that we get?
Most of them will answer Scarlet skin syndrome.
Okay.
Staphylococcal Scarlet skin syndrome. Yeah, the case, first case.
Perfect. So that is the correct answer. Usually they present with this painful skin on the flexural areas, armpits, groin, nappy area. Okay, they can get blisters around the orifice as well. So in this case, on the mouth, and they can get it around the ears as well. They're usually quite miserable, and so I mentioned Nikolsky's sign there, which is a sign where when you gently stroke the skin, okay, it can cause exfoliation of the skin. You can see it's called flaccid bullae. Okay, so there's sheets of the skin lifting off. Okay.
Okay, noted. Okay, for the second case, Dr. Hafsah?
So okay, what answers do we get?
Okay, we have two answers. One is non-evoluting infantile hemangioma. The second one, they put here as a Sturge-Weber syndrome because of pork wine stain.
Okay, so basically pork wine stain. You cannot diagnose Sturge-Weber syndrome based on the picture, by the way, yeah, because it's a syndrome. So okay, and okay, so that's correct. It is actually pork wine stain, and just bear in mind that infantile hemangioma in face syndrome can also present in a segmental pattern. Okay, so 15% of face syndrome, which so pork wine stain is in Sturge-Weber syndrome, and we have the infantile hemangioma in as part of the face syndrome. Okay, and 15% of face syndrome, the hemangioma can occur in a segmental pattern, and therefore you can actually get confused between the two. But the key is the history. So in infantile hemangioma, they actually are subtle or absent at birth. Okay, even if it's there, it's quite subtle, and then they have the rapid growth phase. Okay, a few weeks after that, and then it plateaus, and then it goes through the involution phase. Whereas the part 1 stain, it goes proportionately with the child. And in infantile hemangioma, you can get ulcerations as well. That's another distinguishing feature, which is which you don't really see in part 1 stain. Okay, and how about?
Okay, noted, Dr. Hafsah. So the third one, okay, the third case, most of them answer strawberry hemangioma. Yeah, most of them, strawberry hemangioma.
Okay. So yeah, the correct answer is infantile hemangioma. That's the term we use, and this is solitary, infantile hemangioma on the scalp. And as I said just now, it has it's usually absent at birth, and then a few weeks later, it has this rapid growth phase, and then it plateaus, and towards 1 year old, it kind of involutes, and 70% involutes with at 7 years, 90% at 9 years. So it's important to get the history as well. Was it present at birth? Has it grown rapidly? And has it grown rapidly or disproportionate to the child? And you should assess as well if there's any ulceration, and sometimes some patients can get multiple infantile hemangioma, in which we have to perform further investigations, and we can go through that as a topic for infantile hemangioma on another day if you want.
Okay. We have one question from actually two questions from Facebook. Facebook. One is regarding the hemangioma part. So when do you decide for propranolol for hemangioma? This is from Akpis.
Okay. I think it's very important to assess where the site is. Okay, if there's any ulceration. Okay, if it's affecting the function of the baby. Okay, in terms of eating, okay, vision. So these are among the factors that we take into account before deciding if the patient needs propranolol or not. This is actually quite a subspecialized area. I know a bit about this because I've done a bit of pediatric dermatology, but usually it's under pediatric dermatology clinic. Okay, so make sure you refer to dermatology. Okay, most of them don't need propranolol. Okay, but if as I said, if it's ulcerating, depending on the size, ulceration, and also if it's affecting the function of the patient, we will consider propranolol actually.
Okay. Okay, I give you the last question, Doctor, from Zasa from the Facebook. Doctor, I came across a patient who complained of bullae with hemorrhagic content over the buccal mucosa. Comes and resolves spontaneously, usually one lesion arising each episode. No other skin lesion as well. What are the possible causes and treatment options? Thank you, Doctor. From Ang Ziulin.
Where are the bullae?
In Facebook, Dr. Hafsah.
What's the distribution? So, there are I need to know, basically you have to know what is the distribution. The age matters as well, because some bullous conditions are more common in certain age. Okay, medications are very important because you can get bullous drug eruption as well. So I cannot answer that for you. you have to refer to them basically.
Yeah, I think the dermatology consult is quite important because we cannot give diagnosis based on other people's description. Yes.
That's definitely not.
Yes. Okay, I think that's all from the Zoom question. So I'll give back the floor to Dr. Nurul Yakin.
All right. Thank you, Dr. Iskandar. And thank you, Dr. Hafsah, for a very wonderful and fruitful session. I'm sure all of us really have learned a lot from this interesting topic, skin lesions are definitely amongst commonest problems within our clinical practice. And I'm sure a lot of doctors have learned a vast description on skin lesions. Yeah. Okay, so I think if there is no more questions from the floor, probably we do have some announcement for our next week CME session. Okay, I think there is some suggestion from Dr. Afida. Can we suggest a topic on eczema next? Since a lot of people are asking about it. Yeah, maybe we can.
Yeah, definitely. Yeah, we have very limited time for this because I really want people to grasp the important points on how to describe skin lesions. But eczema actually is a topic. It can be a day conference, or, so
Yeah,
we'll probably, yeah, definitely a good suggestion. We'll write that as one of the suggestions for our next topic.
From Dr. Loba to everyone, HPV would be would be a good topic as well. HPV, human papillomavirus infection. Maybe we can.
The warts called the skin warts, eh?
Probably skin warts. Yeah.
But yeah, it is also a big topic because depending on
another suggestion from Amina, eczema topic, please. Yeah, I think a lot of requests on eczema. Yeah. Yep. So for our next week CME, we're going to have what topic for next week?
By that is by Dr. Sazali lah, regarding all about vaccine.
All about vaccine.
Yes.
Yeah, interesting. So since I think COVID-19 vaccine is one of the in topic right now, the most in thing at the moment. So yeah, let's look forward for COVID vaccine topic next week. All right. If there is no other question or no other suggestion, let us close our session. And I would like to thank everyone. Okay, some question from the audience here asking about CPD points. Unfortunately, we do not have CPD points as per yet, but we are working on it. Hopefully within few more sessions, we're gonna get the CPD point for all of us. All right, thank you everyone for joining us tonight, and we'll see you guys again next week. Thank you. Assalamualaikum.
Thank you.
And